It's now 55 minutes after the hour. I want to welcome everyone back to the ACIP meeting for today. And we will start with the next session on COVID-19 vaccines. Dr. Matt Daly, who is the work group chair for the COVID-19 vaccines work group, will provide an introduction and overview of today's session.
Thanks very much for that, Dr. Lee. So I'm Matt Daly, and I'm the ACIP COVID-19 vaccines work group chair. Next slide, please. That's not for me. Sorry, there's applause in the room. So in terms of COVID-19 vaccine updates, on September 11th of 2023, the FDA authorized the updated mRNA COVID-19 vaccines for use in persons ages 6 months through 11 years of age under emergency use authorizations, or EUAs. In addition, on the same date, the FDA approved the updated mRNA COVID-19 vaccines in persons ages 12 years under a supplemental biologics license application, or BLAs. The next day, ACIP convened, and ACIP voted to recommend vaccination with updated 2023-2024 formula COVID-19 vaccines as authorized under the EUA or approved under BLA in persons aged 6 months and older. And then on October 3rd of 2023, the FDA authorized the updated 2023-2024 formula of Novavax COVID-19 vaccine for use in persons ages 12 and older under EUA. Next slide, please. In terms of the ACIP COVID-19 vaccines work group work since that May 12th meeting, we've met several times. We have reviewed and discussed COVID-19 vaccine safety, including data that Dr. Shimabukuro presented yesterday afternoon and reviewed for us. And then we also discussed a number of important COVID-19 vaccine implementation issues. Next slide, please. So for today, we will first hear from Dr. Shannon Stokely, who will review a number of aspects of COVID-19 vaccine implementation. Following that, we'll hear from Dr. Megan Wallace, who will provide some additional COVID-19 policy updates, followed by a discussion. Next slide, please. I just want to sincerely thank all the COVID-19 vaccine work group members who've been working for years at this. Too many meetings to count, but that includes ACIP members, ex officio and government members, our CDC lead, Dr. Wallace, liaisons, as well as consultants, and thanks to you all. Next slide, please. And then a number of CDC participants who make all of this happen. Next slide, please. So I'll turn this over to Dr. Stokely.
Thank you. So good afternoon, everyone. I'm Shannon Stokely. I'm with the Immunization Services Division, and today I'll provide an update on the implementation for the 2023-2024 COVID-19 vaccines. So next slide. And so I'll start by covering some of the changes with the transition from the U.S. government COVID-19 vaccination program to distribution through the commercial market. Next slide. So as mentioned earlier, the COVID-19 vaccination program, or the federal program, discontinued on September 12th of this year as applied to the bivalent Moderna and Pfizer-BioNTech vaccines, and then on October 3rd as it applied to the ancestral or the original Novavax COVID-19 vaccine. And now vaccines all the current COVID vaccines are available on the commercial market. And although the U.S. COVID-19 vaccination program has ended, providers are encouraged to continue administering COVID-19 vaccines at their locations and also participate in vaccines.gov, where they can list vaccine availability at their location. With the end of the federal program, there have been changes to provider agreements and to data reporting. And so now vaccine data reporting has transitioned to routine reporting processes for jurisdictions, and this really applies to immunization information systems and relying on the state policy for reporting to the vaccine registry, but also reporting to CDC. Next slide. So although a COVID-19 vaccine has been commercialized, updated vaccines are available to most people living in the US at no cost through their private health insurance or through Medicare and Medicaid plans. So private health insurance plans that are ACA compliant are required to cover COVID-19 vaccines from an in-network provider at no cost sharing. And then vaccines are also covered under Medicare Part B without cost sharing. And then I think it was mentioned earlier this morning through the Inflation Reduction Act, that eliminated cost sharing for all ACIP recommended vaccines under Medicaid and Medicare Part D. We also have the Vaccines for Children program, which provides vaccine at no cost to children through age 18 years and children who meet at least one eligibility criteria, and that is being Medicaid eligible, uninsured, American Indian or Alaska Native, or underinsured. And then finally, we have the Bridge Access Program, which provides vaccines at no cost to adults aged 18 and over who are underinsured or uninsured. Next slide. Overall, there is an increasing supply of vaccine to meet demand. And as mentioned, all three 2023, 2024 COVID vaccines are available. With the transition of the vaccine to the commercial marketplace, there have been some reports of initial delays in distribution and questions about adequate supply. So one thing just to mention, when you transition from the federal vaccination program to commercial distribution, they are very different systems. So under emergency conditions with a federal distribution system, millions of doses were distributed within a very short amount of time. But with the transition to the commercial market, distribution of COVID vaccines is now similar to that of routine vaccines. So supply is distributed over time to meet demand rather than all at once. And it's just not going to look the same as how it was under the public health emergency. There were reports of delays in distribution early on and shipments taking longer than expected, but this has significantly improved, and we continue to work with our jurisdictional partners to optimize supply and distribution. And we also continue to have conversations with manufacturers and distributors to ensure timely distribution. Next slide. So now I just want to provide a little bit more information about the Bridge Access Program. Next slide. And so as mentioned before, the Bridge Access Program provides no-cost COVID-19 vaccines to adults that do not have health insurance and adults whose insurance does not fully cover all COVID-19 vaccination costs. All CDC-recommended COVID-19 vaccines are included in this program, and the program will continue through the end of December of 2024. The Vaccines for Adults program, which has been proposed in multiple presidential budgets, would be a long-term solution to ensure all adults have access to recommended vaccines, including COVID-19 vaccine at no cost to them, but as we know, that program doesn't exist at this time. So the Bridge Access Program is really critical to fill that gap for or underinsured adults. Next slide. So who can get vaccines through the Bridge Access Program? That includes adults age 18 years and older who are uninsured, meaning they don't have health insurance. They can find free vaccination at any of the participating Bridge Access Program sites, and I'll describe those sites in a moment. Adults age 18 years and older who are underinsured, meaning they have insurance, but the insurance doesn't cover all the costs, such as a copay. They can find free vaccine at participating Bridge Access Program sites, which are in network with their insurance, and that's a really key point to mention. Patients may not have copays waived at Bridge sites, which are not in network with their insurance. And so patients will need to really understand within their insurance plan where the in-network providers are and seek vaccination at those locations. And so this may involve seeking vaccination within a specific health system or within a specific state or a specific set of retail pharmacies or a certain type of provider. And it's important to note that patients do risk receiving bills for vaccination if they accidentally misrepresent their insurance coverage when seeking vaccination through a Bridge Access Program site. Next slide. So I'll talk a little bit more about the Bridge Access Program site locations. And so we are leveraging existing public health infrastructure through jurisdiction immunization awardees and local health departments and HRSA-supported health centers to provide no-cost vaccination to adults without health insurance. Adults without health insurance can get vaccines at HRSA-supported health centers enrolled in their local health department's 317 program and also participating in the Bridge Access Program. And members of federally recognized tribes can also get no-cost vaccines at Indian Health Service, tribal or urban Indian health program facilities, regardless of the provider's enrollment status with the Bridge Access Program. And last, we did modify contracts with CVS, Walgreens, and eTrue North to provide no-cost vaccination at these retail pharmacies to adults without insurance and adults whose insurance doesn't fully cover the cost of vaccination. And just of note, eTrue North is a pharmacy aggregator, meaning they enroll smaller and independent pharmacies into the Bridge Access Program. And there also may be community events or pop-up sites with these groups as the season continues. And again, we encourage people to visit vaccines.gov to find a provider near them who is offering vaccine. It is a requirement that all of the participating sites list their vaccine availability on vaccines.gov. Next slide. So I'll just provide a little bit more information about the numbers around the Bridge program. Again, we monitor vaccine doses for the program, both through our pharmacy partners and our immunization program partners. The contracted pharmacies are required to provide to us on a daily basis the number of sites that are operating and how many doses have been administered. And then for our public health partners who receive COVID vaccine doses through CDC, we're able to track the orders, including where they go, the number of providers ordering vaccine, and the number of doses that were ordered. So currently there are over 24,000 contracted pharmacy locations and over 380,000 doses have been administered by these sites. And there are now over 4,400 public health safety net providers that have placed more than 6,100 orders for over 287,000 doses of COVID-19 vaccine using their 317 funds. And nationally, 81% of people without insurance are estimated to live within a 5-mile drive distance to a Bridge Access Program provider. Next slide. And now I just want to say a few words about vaccination coverage for the updated COVID-19 vaccine. Next slide. So here's a snapshot of various data sources that will be used for data reporting. I'm not going to go over every system, but you'll see some of these should look familiar to you. We continue to get data from immunization information systems, from our National Immunization Survey. We'll be getting data for claims data, as well as other surveillance systems. Next slide. So today I'm just going to provide some preliminary data about vaccination coverage. This is from our National Immunization Survey. We have an adult COVID module and a child COVID module that's administered every week. For those not familiar with the NIS, this is a random digit dial telephone survey of cell phone numbers. And vaccination status is self-reported by the respondent. And just to caution that sometimes there may be the potential for overestimation since it's self-reported. But looking at our data for the week of October 8th through the 14th, and for adults 18 and over, we see that an estimated 7% are reported to have received a COVID-19 vaccine. And this is the 2023-2024 vaccine. We also assess vaccine intentions among individuals who have not received a vaccine, and we're seeing about 25% of adults say they will definitely get vaccinated, and about 38% saying they probably or definitely will not get vaccinated. Next slide. We also have data on sociodemographic variables. I know it's maybe a little difficult to see in this slide, but we do find that COVID-19 vaccine was more frequently reported among adults who were older, had health insurance, and had higher incomes. Next slide. So now I just want to show data for children, and this is children through age 18 or 17 years. Again, the time period is October 8th through 14th, and this is parents reporting the vaccination status of their children. And we see that about 2% of children were reported to have received a COVID vaccine. Next slide. So lastly, we show that a little over a quarter of children have a parent that have said they definitely will get their child vaccinated, and about 38% have a parent that said they definitely will not get vaccinated. Next slide. So just to summarize our vaccination coverage data, again, for children, approximately 2% are reported to have received a vaccine, and 7% of adults have reported to receive a vaccine. That was my last slide, so sorry about that. But happy to take questions afterwards. Thank you.
Thank you. This presentation is now open for questions. Ms. Bata? Ms. Bata, sorry, I can't hear you.
I'm sorry, I didn't hear you call my name. A little distracting right now here in the auditorium. Do we have any status on vaccine supply? In particular, we're seeing it very difficult for our pediatricians to get the Moderna product. So I'm wondering about that, and we have heard reports from some of our community members that they've gone to a pharmacy through the Bridge program and were charged for the vaccine.
I'll have to get back to, my understanding is that vaccine supply is available for ordering even for Moderna vaccine. I'll probably have to talk with you offline specifically for your location.
We'll move on to Dr. Kimberlin.
David Kimberlin, AAP Red Book. 2% of children have received the current version of the vaccine. 40% of parents say they're not going to get their children vaccinated. 7% of adults have received the current vaccine. 40% or so say they're not going to get vaccinated. I don't even really have words for this. I appreciate everything that, you know, the AAP is doing, that ACIP is doing, CDC and so forth to make recommendations, but the recommendations are not being heard. And I would suggest that at some future ACIP meeting, additional detail be provided on communication strategies, not additional adjustments to the current recommendations, but how are we trying to do better as a country to get those recommendations to the people that need to hear them in a way that they want to hear them, and they're receptive to being heard. I don't know what that is, but until we address that issue, it doesn't matter how many recommendations we make. It's simply not going to, it will fall upon deaf ears, as they say.
Thank you. Dr. Stokely, I'm going to keep going, and hopefully you have water on that end. Dr. Paling?
So two things. I wanted to follow up on Ms. Bata's comment because in North Carolina, providers are reporting trouble with both Moderna and Pfizer for the young children. And so I think this is a important issue that needs to be investigated to support people. Because the second is I want to, first of all, thank you guys for the bridge program. I think this is a really important program. I also very much appreciated the commentary that you have to figure out which pharmacy or location is in network. I'll have to tell you, I was unaware that I had a pharmacy that was in network, and I believe many people have been caught unaware by that. And so that is a really important message to help with access. Thank you.
And just, sorry, this is Sarah Meyer. Just to comment on the points that have been made about pediatric vaccination, Dr. Stokely, mentioned this, but from what we're hearing, it's not necessarily a supply issue. It's not necessarily a distribution issue, although, of course, as alluded to, there have been some things that have had to be worked out through commercialization. I think early on in the rollout, there was a little bit of a delay in getting the Moderna supply, but that has improved. I think what we're hearing about more and more is just how difficult it is for pediatricians to be able to carry these products, to store them, to stock them, just the kind of implementation issues around providing this vaccine. And I think we do have some good updates, which I know Dr. Wallace will be talking about in terms of some of the new guidance that we hope makes it more implementable in the pediatric office, but we are hearing about some of those issues. From the VFC side, we have been continuing to increase the allocations so that states can order more VFC doses, and we have recently published an addendum to our VFC operations guide that gives some additional flexibilities around borrowing and things like that to help further smooth some of the implementation challenges that pediatric providers are facing.
Thank you, Dr. Meyer. Dr. Talbot.
This goes along with Dr. Paling's comment, and it's another plug for vaccines for adults, but the bridge program is amazing. That took a whole bunch of work, but the population that's using the bridge program does not have the time, the energy, the bandwidth to find the pharmacy or the person that can deliver the vaccine. These are the folks that are working 2 jobs and don't have insurance. And so I applaud the work. It was an amazing amount of work. But I just think it further reiterates the need for just standard funding for adult vaccines. So thank you.
Thank you. Dr. O'Leary, I'm just going to jump in for a moment and highlight, while I certainly believe that acceptability is a component of the low uptake, I do believe the access issues are real, not just supply though, it's really the whole financial model for vaccination. As these vaccines are getting more expensive, we have to recognize we're asking pediatricians, family practice offices, and now adult practices to bear the cost of vaccines that may not get reimbursed at cost, and also may not, they might lose doses. And particularly since uptake is unpredictable right now, it makes it a challenge to understand how many doses you should stock. So it's kind of a chicken and an egg thing, but I do find this very challenging. Let me just say that the vaccines for children's program, the Bridge Access program, and the vaccines for adult program are unbelievable. And I don't know where we would be without it. And I really appreciate all of the efforts it goes into funding vaccines because it does make it at least feasible. But until we change that model of payment where the upfront cost is borne by the providers, it makes it a very challenging thing to continue to scale up and all the other implementation considerations. I'll just stop there. Dr. O'Leary.
Well, Dr. Lee, you said a lot of what I was just going to say. Primary care is stretched incredibly thin right now. Staffing shortages, financially, a lot of these are essentially small businesses with very thin margins. And with the recommendations for COVID vaccine in particular, essentially very similar to our recommendations for influenza vaccine, trying to vaccinate your entire, patient cohort essentially from 6 months on up. That's one thing to do that with influenza vaccine, where the vaccine products are, not all that expensive. But when you're talking about a product that's $120 to $130 for your entire patient population, that's a real challenge for these clinicians to purchase that product. So this fragmented system of the way we deliver vaccines is really broken. And, as Dr. Kimberlin pointed out, with the difference between what we're seeing, 2%, and what parents would be willing to do, which is, close to 60 or 70%, that difference is delivery. So if this product is available in every pediatric and family medicine office and clinicians give a strong recommendation, we're going to get much, much closer to those 50 and 60% numbers that we see, for example, with influenza vaccine, which pediatricians and family docs have been working for years to build up to. So I think, if somehow, I don't know how the pricing was determined for these these products, but that it's really a lot to ask of these clinicians to purchase these very expensive products for their entire cohort when they don't even know if they're going to get paid back. So I will stop there.
Thanks, and sorry to jump in before you, Dr. O'Leary. Dr. Deshawn?
Yeah, hi, I'm Dana Deshawn from NAP, and 25 years as a pediatric nurse practitioner in a primary care office. And I guess I was disappointed that there was not the single dose option for the young children as well. So just that feedback that would be really a great option. Our facility are going to be having the COVID-19, but only in certain locations, mainly just because of the price that's also associated with it. And then having the availability also we've ran into issues with that. I think that we just have to come together with a cohesiveness of all pediatric and family providers with the recommendation, because there are a lot of opinions out there, and we know that families do listen to their providers, and so when we come forward with that certainly is helpful in addressing their concerns. And then I also would think if there was a availability of funding for those mobile vaccines in vans or whatever to go to those areas, that would be amazing as well. Thanks.
Thank you. And Ms. Hayes?
Yes, Carol Hayes with the ACNM. So I have a friend who's a Kaiser patient in Georgia, and she was unable to get the vaccine because Kaiser could not figure out what the billing code was for it. So, and I had a similar experience in trying to get the vaccine myself when I went to a local pharmacy. They had access to order the vaccine, but they couldn't figure out how to enter it into their system. These large computer systems could not get the right ICD-10s in there. So it's like, I feel like we need to be patient. Dr. Kimberlin, don't freak out that there's a low vaccination rate so far. I really think this is all just a computer glitch that needs to be worked out.
Thank you. Dr. Meyer or Dr. Stokely, is there anything else you'd like to add or comment on? Okay, I don't hear any or see any hands raised. So we will move on to the next presentation. Dr. Megan Wallace will be discussing COVID-19 vaccine policy and next steps.
Thank you, Dr. Lee. Next slide. I'm going to start with a brief update on the current COVID-19 epidemiology. Next. This slide shows the trends in the weighted variant proportion and nowcast estimates in the United States by 2-week increments on the left, and a more detailed breakdown of the nowcast estimates for the first 2 weeks in October on the right. As has been the case for the past few months, there are quite a few SARS-CoV-2 lineages currently circulating, but the vast majority of these are still XBB sublineage variants. Next. The figure on this slide shows the weekly population-based rates of COVID-19 associated hospitalizations by season from COVIDnet. For the purposes of this figure, a season is defined as October through September, so the season covers a full 12 months. Each line color represents a different season, with the most recent season depicted by the green dotted line. As we discussed at last month's ACIP meeting, hospitalization rates tended to be lower this past year than in previous years. However, we typically see COVID-19 hospitalization rates begin to increase in November or December, so it's still too early to predict how COVID-19 hospitalization rates will compare this upcoming respiratory season to past seasons. Next slide. On this slide, we are still looking at the weekly population-based rates of COVID-19 hospitalizations, now stratified by age group over the past year. As we've seen before, the highest hospitalization rates continue to be in those 65 years and older, and this is the group in which the recent increases in hospitalization rates is most apparent. Next slide. The figure on this slide shows the number of weekly COVID-19 new hospitalization admissions over time from the National Healthcare Safety Network. When we look to the far right side of the figure, despite hospitalizations being relatively lower than we've seen at previous points, we are currently seeing over 18,000 new hospitalizations a week. Next. This figure is similar to the one we saw on the previous slide, except now we are looking at the number of weekly COVID-19 deaths. Like hospitalizations, the number of weekly deaths is currently lower than what we've seen in the past. However, we are still seeing over 1,200 deaths a week. Next. Now I'll review the current COVID-19 vaccine policy. Next slide. So as you all know, and as Dr. Daly mentioned in his slides, ACIP met on September 12th to review the available evidence for updated COVID-19 vaccines, which have a monovalent XBB.1.5 component. ACIP recommended updated COVID-19 vaccines as authorized under EUA or approved by BLA in persons 6 months of age and older. This includes Moderna COVID-19 vaccine in persons 6 months and older, Pfizer-BioNTech COVID-19 vaccine in persons 6 months and older, and Novavax COVID-19 vaccine in persons 12 years and older. All anticipated updated vaccines are now authorized or approved, and in the next few slides, I'll walk through the recommendations in more detail. Next. Children in the youngest age group, 6 months to 4 years, without immunocompromise are recommended to receive an initial series of mRNA vaccine with at least 1 dose of 2023-2024 vaccine, and these doses should be homologous. Next. This slide shows an infographic of the vaccine recommendations, which I'll use to walk through the recommendations for each age group. I won't spend too much time on each of these today, but these infographics are available on our interim clinical considerations website. So for children ages 6 months to 4 years, those who are unvaccinated should receive 2 doses of the updated Moderna vaccine or 3 doses of the updated Pfizer vaccine, as depicted on the leftmost part of the slide. Those who are vaccinated, shown on the right of the slide, with 1, 2, or 3 or more doses, should also receive at least 1 or 2 updated doses of mRNA vaccine, depending on which manufacturer they received initially. Next. Next slide. With regard to interchangeability of COVID-19 vaccines, which we know is an important consideration in this age group, we previously had this language in our interim clinical considerations detailing the exceptional circumstances in which a different age-appropriate COVID-19 vaccine may be administered. However, this language was leading to implementation barriers among providers. Next. In response, we've updated our language around interchangeability in our interim clinical considerations to clarify the circumstances under which it's acceptable to administer COVID-19 vaccine doses from different manufacturers. The bolded text represents our changes, so you will note we moved away from the exceptional circumstances language and now simply refer to these as circumstances. We've also provided additional descriptions for what these circumstances can be. The text now reads, COVID-19 vaccine doses from the same manufacturer should be administered whenever recommended. In the following circumstances, an age-appropriate COVID-19 vaccine from a different manufacturer may be administered. The same vaccine is not available at the vaccination site at the time of the clinic visit. The previous dose is unknown. The person would otherwise not receive a recommended vaccine dose, or the person starts but is unable to complete a vaccination series with the same COVID-19 vaccine due to a contraindication. Another important note here is that a VAERS report is not indicated in these circumstances. Next. Additionally, also in an effort to simplify pediatric vaccine recommendations, we have updated guidance for children who transitioned during the initial COVID-19 vaccination series from age 4 to 5 years, and children who are moderately or severely immunocompromised and transition from age 11 years to age 12 years to receive the age-appropriate dosage based on their age on the day of vaccination. Next. Moving now to the recommendations for people aged 5 years and older. All people aged 5 and older are recommended to receive 1 dose of updated 2023-2024 vaccine. mRNA COVID-19 vaccines are authorized or approved for ages 6 months and older, and Novavax COVID-19 vaccine is authorized for ages 12 years and older. One important caveat to this single dose recommendation that I want to mention is that unvaccinated persons receiving Novavax COVID-19 vaccine should complete a 2-dose initial series. Next slide. This is the visual for the recommendation for those aged 5 to 11 years. Note that the dose may be either Moderna or Pfizer-BioNTech, regardless of vaccination history. And as noted earlier, Moderna's dose is the same for the younger age group. Next slide. This slide shows the recommendations for those aged 12 years and older, for which Novavax is also an option. For Novavax, those that are previously unvaccinated are recommended for 2 initial series doses, while those that have any previous vaccinations are recommended for a single updated dose. While for the mRNA vaccines, it is a single dose regardless of past vaccination history. Next slide. For all age groups, persons who are moderately or severely immunocompromised are recommended to receive an initial series of COVID-19 vaccine and then at least 1 updated 2023-2024 COVID-19 vaccine dose. They may also receive 1 or more additional updated COVID-19 vaccine doses informed by the clinical judgment of their healthcare provider and patient personal preference and circumstances. Next. This slide shows the recommendations for those aged 6 months to 4 years. On the left, you can see that anyone who is unvaccinated is recommended to receive 3 doses. On the right, under the gray vaccinated box, you can determine how many doses are recommended now based on how many doses they received by manufacturer on the second row. Next slide. These are the same recommendations with the vaccines for 5 to 11-year-olds who are moderately or severely immunocompromised. Their recommendations are the same as those for 6 months to 4 years with one exception. If you look to the far right side of the figure, you can see that once the initial series vaccination is complete, for any additional doses, they can receive either mRNA vaccine. Next slide. Finally, we come to those 12 years and older who are moderately or severely immunocompromised, for which Novavax is also an option. The important thing I want to point out here is that Novavax does not have an initial series specific to those who are moderately or severely immunocompromised. So they have the same 2-dose initial series recommendation as for those who are not immunocompromised. But like the mRNA vaccines, they do have the flexibility to receive additional doses. Next slide. I want to end with providing a preview of our upcoming policy discussions. First on the horizon is the consideration of additional COVID-19 vaccine doses in older adults. We anticipate this discussion during the February 2024 ACIP meeting, and if we aim to bring that before ACIP at that meeting, the policy discussion will occur prior to individuals reaching 6 months since their last dose. Then we will pivot to preparations for future COVID-19 vaccine formula updates, with those discussions beginning at the June 2024 ACIP meeting. As always, we will be continuously monitoring vaccine effectiveness, vaccine safety, and COVID-19 epidemiology, and COVID-19 vaccine recommendations can be updated if needed. Next. In closing, I want to thank this incredible group that makes all of this work possible. Next. Thank you.
Thank you very much, Dr. Wallace. This presentation is now open for questions. Dr. Sanchez.
Thank you for that. It remains complicated, very complicated. But one question with the 6 months to 4 years, what if they have been vaccinated but not so-called up to date, and we don't know what vaccine they received? So in other words, if they received one dose of either and they don't know which, or as it often happens, locations are only giving one. Like for instance, at Nationwide Children's, we only have Moderna. So if you don't know, do they get more doses? No.
Thank you, Dr. Sanchez. So we have a full appendix that lists all of the different iterations of things that can happen based on the number of doses that people think that they received in the past. But this is an area in which interchangeability is allowed. And so I think, at the very least, they would receive one updated dose. And I think that would be whatever is in their office at the time.
And if they've not been vaccinated, well, if they had not been vaccinated previously, they would require 2 doses of Moderna, 3 doses of the Pfizer. And so you don't know which one they received, or it's not available. Do you then give 3 doses? That was the old recommendation. Is that still applicable?
If you believe that they've received at least one in the past, I don't think we would recommend 3 additional doses. I think it would have to do with the age but they would, I think, at least receive 2 updated doses if they're coming in.
Dr. Sanchez, does that answer your question?
Sorry.
Okay, thank you. Dr. Paling?
So thank you for this presentation, and thank you for the clarification. You've clearly been listening to feedback and modifying the recommendations and the considerations based on this feedback, and that is really much appreciated. One of the points that we made is the vaccine coverage in young children, and there is a misperception that children don't get very sick with influenza. And so do you have any updated information on the hospitalization rate among children?
Thank you. If you can go to my first backup slide. So I think, the hospitalization rates among children are, certainly lower than what we see in older adults. But I think, if we consider them compared to other things, I think there's still a substantial amount of morbidity here. And, particularly those in the youngest age groups, less than 1, I think they have relatively, higher hospitalization rates, all things considered. And in particular, we're starting to see those rise as we move into the fall respiratory season. And I will also say on the line is Dr. Havers from COVIDnet. So if she wants to add anything, I defer to her.
Yeah, I think, so the data I think that's showing there is from the last year. And I think, as Dr. Wallace pointed out, that we still see the highest rates of hospitalization in very young infants, particularly among those less than 6 months of age. We have seen a rise recently, but as we've seen over the last couple of weeks, hospitalization rates have been declining, but we don't know what to expect over this next year. But I would say that very young infants and then school-age children have lower hospitalization rates than the very young infants. But as you can see on the slide, hospitalization rates by age group have been going up, but have started to decline recently.
Thank you. Dr. Cotton.
Thank you. So this is a general question, not so much on this specific talk, but perhaps actually relating to the last talk. These rates of revaccination or vaccination are really abysmal. And when I see patients, they're actually really confused. Many tell me that they're up to date, although their last vaccine was in 2021. They said, no, I had 3. They're kind of, many are amenable to vaccination when I bring it up, but they are not necessarily knowledgeable, and I think there's a lot of confusing information out there. It seems like we could do a better job with just general education of the public. And I'm wondering if the CDC has plans for that. I think it's not clear whose responsibility that is, but from a public health perspective, I'm wondering if the CDC has a plan or anything they might be rolling out or any updates. Thank you.
Yeah, thank you for that comment. I mean, I think this season we have been really trying to focus on how to simplify and streamline all the information that is being shared with both the public and providers, because it's not just COVID and new COVID information, but RSV, which is brand new to everyone, and flu, and the timing, and the populations of interest. So we're really trying to take a little bit more of a integrated and comprehensive approach, but that would also include the COVID-19 information. So we've been working on a number of materials, both for the public, but also for providers. We've been putting out, provider toolkit, including additional clinical education resources to help make that more clear to the provider community. We've been continuing a lot of our communication efforts geared towards the public. We have some additional initiatives. So for example, with the Bridge program, communications campaigns, since educating that segment of the population that this program even exists and how to access it is important. So we have been trying to work through that this season, taking an integrated approach to the 3 vaccines that protect against respiratory viruses. But I think it's also, I think what we're learning through some of our surveys and other work that we're doing is, there's certainly a lot of vaccine fatigue in the public. There's also in the provider community a concern that patients don't want this vaccine, and if they bring it up, it could harm their ability to talk to them about other vaccines and things like that. So I think we're trying to not only approach it from education and supporting the public, but also supporting our providers in having those conversations and answering their questions and things like that. So.
Thank you very much for all that work you're doing. I guess there are members of the press who are listening, and I know that many of my patients actually get a lot of their information from outside of standard medical channels or CDC channels. So I would just encourage members of the press to convey appropriate information about vaccines, and that's yet another way. I think many people who signed up as journalists and whatnot didn't necessarily do so to save lives, but we've learned during the pandemic how important their role is. So for members of the press listening, please help us. It is a multi-pronged approach, and I appreciate the thoughtfulness on behalf of the CDC. Thank you.
Thank you. Dr. Daly?
Yeah, I would just add to Dr. Cotton's comments, and you said that so well earlier, appreciate that. I just taken a big picture view, 1,200 deaths a week from COVID. Those deaths are largely vaccine preventable. And if you haven't gotten a vaccine this fall, you're not adequately protected. And that's the message that I think we're all trying to convey. Again, 1,200 deaths a week, largely vaccine preventable. Get a vaccine this fall. If you could go back to slide 38, I think, for just a sec. So I agree with Dr. Paling that this is important, because what we were finding was we're transitioning to vaccination in the medical home by and large and other settings. And then those settings are probably going to carry just one of the 2 COVID vaccines for the practical reasons that Dr. O'Leary highlighted. It's so expensive, it's challenging. And so what we were finding was patients who would come to their medical home and then essentially be turned away because their medical home wasn't carrying the vaccine, the mRNA product specifically, that they had received previously. And this was creating barriers. So I just want to thank everyone at the CDC who's worked really hard to change this language to a little bit broader language, and then thank our colleagues at the FDA. And I realize that this is both scientific and regulatory, but this is an example of the federal agencies and public health agencies working together to help remove barriers so that when somebody shows up
a kid, in this case, under the age of 5, they can be vaccinated. So a big thanks to you guys.
Thank you, Dr. Daly. Dr. Good.
Thanks, Dr. Lee. Thank you for a great presentation. I just have one potential suggestion. I love the infographics, but if there's any way to add the dosing intervals to there so you don't have to go to another place to sort of find that information would be very, very helpful.
Okay, thank you.
And then just one last smaller comment for me, which is as we're working on not only vaccinating our patients, and I will say, for whatever reason this year, we seem to have less hesitance than we've had in years past, but for the respiratory viral vaccines, let me just speak broadly about them. But one question I actually have is whether or not we're tracking data on healthcare worker vaccination. And the reason I say that is with the CMS mandate going down, I am very curious about uptake at the different institutions and whether or not, there's a difference that we're seeing between flu and COVID, for example, in terms of healthcare personnel vaccination in order to protect the patients that we care for. Do you have any information on that? Or are we tracking on that going forward?
I know we annually monitor flu vaccination among healthcare workers through different sources. We do an annual survey of healthcare workers to assess their vaccination status, and I think we do ask about COVID in there. I think there is some monitoring of vaccination status of long-term care facility staff, and that is updated on our I think it's the COVID net site. But I take your point about the importance of monitoring vaccination status among healthcare workers, and we can get back to you on that as well.
Yeah, thank you. It's an opportunity for us, partly because, we're caring for really medically fragile patients much of the time. And so to be able to make sure that we as healthcare providers are protecting our workforce and protecting our patients, I think it would be really helpful. And I will just say that since masking has gone down, we are certainly seeing more respiratory viral transmission happening in healthcare delivery settings since that has happened. So there were some benefits of masking, which is a lot of things got better. Okay, any other questions? All right, thank you so much to Drs. Daly, Stokely, and Wallace for providing this updated information on COVID-19 vaccines for the committee. We will move on next to pneumococcal vaccine session. Dr. Kobayashi will be, let me just confirm. I have Dr. Kobayashi providing work group updates and next steps. Is that correct? Oh, terrific, thank you.
Good afternoon. Oops. Okay. Today, on behalf of the pneumococcal vaccines work group, I will present a brief summary of pneumococcal disease epidemiology and pneumococcal vaccines in development for adults. Oops. Okay. The pneumococcal vaccines work group reviews current data on pneumococcal disease burden and on the efficacy, effectiveness, immunogenicity, and cost-effectiveness of pneumococcal vaccines, and assesses the strength of evidence, reviews current pneumococcal vaccine recommendations considering up-to-date evidence, and develops revised or updated policy options for pneumococcal vaccines as needed. These are the current members of the work group, chaired by Dr. Catherine Paling, and Dr. Paling and Dr. Sarah Long are the two voting members on the work group. We also have the following ex officio members, liaison representatives, and consultants. And here are the CDC contributors and grade ETR consultants who support the work group activities. I'll start with a brief overview of the pneumococcal vaccine recommendations. Currently, there are two types of pneumococcal vaccines recommended in the United States. A pneumococcal polysaccharide vaccine, or PPSV23, that has been recommended since the 1980s, and pneumococcal conjugate vaccines, or PCVs. The first pneumococcal conjugate vaccine, PCV7, containing 7 pneumococcal serotypes was recommended for children in 2000. And 10 years later, in 2010, PCV7 was replaced by PCV13, containing 6 additional serotypes not included in PCV7. PCV13 was the first conjugate vaccine that was recommended for adults in 2012. In 2021, 2 new pneumococcal conjugate vaccines, PCV15 and PCV20, were recommended for adults. These vaccines contain additional serotypes not included in PCV13 and were initially recommended for adults who had not received a pneumococcal conjugate vaccine or whose vaccination history is unknown. Later, the recommendation for PCV20 was expanded to include adults who previously received PCV13. PCV15 and PCV20 are now recommended for children. And as you can see, adult pneumococcal vaccine recommendations have been updated multiple times since 2012. Now I will briefly summarize pneumococcal disease burden in adults. Among adults of all age groups, there were an estimated 100,000 non-invasive pneumococcal pneumonia hospitalizations and 30,000 invasive pneumococcal disease or IPD cases, with 3,000 IPD deaths every year prior to the COVID-19 pandemic. Preliminary data show an increase in the number of IPD cases in late 2022 after reductions in IPD incidence across all age groups early in the COVID-19 pandemic. This increase was seen with other invasive bacterial infections, especially among children. This figure shows changes in invasive pneumococcal disease incidence among adults 65 years and older. The incidence of PCV13 type IPD is shown in purple, and IPD caused by all pneumococcal serotypes is shown in black from 2007 through 2021. Early in the COVID-19 pandemic, IPD incidence decreased across all age groups, and the incidence reached a historically low level. However, IPD incidence increased in 2022. This graph shows the distribution of pneumococcal serotypes that cause invasive pneumococcal disease in adults 65 years and older in 2018-2019 and 2020-2021. And approximately 40% of IPD cases were caused by pneumococcal serotypes not contained in any of the existing vaccines, shown in purple. There are new pneumococcal vaccines in advanced stages of development that are expected to provide broader serotype coverage compared with existing vaccines. The currently recommended vaccines PCV15, PCV20, and PPSV23 in the serotype coverage are shown on the top. There are 2 24-valent pneumococcal vaccines in advanced stages of development for adults. These vaccines provide comparable serotype coverage compared with PPSV23. The 21-valent vaccine at the bottom does not include some of the serotypes contained in existing vaccines, but does include 8 additional serotypes not contained in existing vaccines. And phase 3 trials in adults are currently ongoing. After a brief break in the summer, the pneumococcal vaccines work group will be reviewing evidence on use of 21-valent pneumococcal conjugate vaccine V116 for adults. Submission of a biologics license application for V116 to the FDA is anticipated in Q4 of 2023, with possible FDA approval in the first half of 2024. The workgroup plans to review evidence to support ETR domains, including epidemiology of pneumococcal disease among U.S. adults, assessment of pneumococcal disease caused by serotypes not included in V116, but included in existing vaccines, phase 2 and 3 clinical trial data on V116 among adults, feasibility and resource use involved in V116 used among adults, and health equity considerations. And we will aim to have an ACIP vote on policy options shortly after FDA approval of V116. This is the end of my presentation. Thank you very much, and I'd be happy to take any questions.
Thank you very much, Dr. Kobayashi. Dr. Talbot.
Yeah, thank you. Great presentation. We talked a little bit in the last 2 days about vaccine recommendations that have been stuck. And since the 1980s, you mentioned we've been using the polysaccharide vaccine. Will you have the opportunity to review the polysaccharide vaccine and determine if that's still the best vaccine to keep on the adult schedule?
Thank you for that question, Dr. Talbot. We will definitely be revisiting the current recommendations as we start the discussions. I understand that there's a lot of interest in simplifying vaccine recommendations in general, so that will continue to be our priority.
I think it's not just a matter of simplification, although I'm a big fan of simplifying the pneumococcal guidelines. But the polysaccharide vaccine is a sugar vaccine, and older adults do not create a T-cell response and get blunting of the B-cell response with the use of the polysaccharide vaccine. And so as a person who wants to save all my older colleagues and friends and neighbors and Americans, I'm not so sure it's the best vaccine for them. And we've continued to use it even though newer conjugate vaccines, which provide a better immune response, are available. So I think for me, it's not just about simplification, it's about having a better vaccine for older adults.
Okay, thank you. We'll go on to Dr. Lair.
Thank you. I'd like to use this opportunity to go back on my soapbox. I still have insurance companies which have not approved PCV15 for infants, let alone PCV20. So I'm faced with giving them PCV13, which is not recommended by the ACIP at this time. I would know that some insurance companies have already approved nirsevimab, including some which have approved nirsevimab, but not the PCV15 or the PCV20. It is really frustrating and very hard to be a practitioner and not know what vaccine to give because I don't know what the insurance is going to cover. So my plea is for all insurances to cover ACIP recommendations as soon as possible. I know that is possible because I have one that says as soon as it is published in the MMWR or approved, actually approved by the CDC director, they will cover it immediately. So that is my plea. Thank you.
Dr. Wharton, is there somebody who could speak to that in some way?
I don't know if anyone from either CMS or ACIP would have a comment on that.
Hi, good afternoon or good morning. This is Jessica Grubb with ACIP. I mean, I think we'll definitely take that back as a trade organization. I don't know that I could make a statement today, but definitely we'll take that back to our team.
Okay. Thank you. And thank you, Dr. Lair, for bringing that up. Yes, we made those recommendations a very long time ago now. Dr. Sanchez.
I just wanted to add to Dr. Talbot's comments that it's not with the Pneumovax, the 23 valent is not just adults, it's really in pediatrics. And then whether those children who have some immunocompromising condition or in my patients, it's the cochlear implants secondary to congenital CMV related hearing loss. Those who received the pneumococcal 23 valent polysaccharide vaccine, whether they should subsequently receive the PCV20. And I think that should be also reconsidered.
Thank you. Dr. Paling?
So I wanted to thank you, Dr. Talbot, for your comment, and thank you, Dr. Sanchez, about PPSV 23. I do want to publicly state that I'm hearing from a lot of allergy and immunology folks that do like the PPSB for helping them evaluate the immune system. And so there is, they did want me to state that there is still use for it, but maybe in a different function.
I'm speechless, which is hard to believe. I think we can stockpile some of that for the allergists and immunologists, but I think for use, I think it's a horrible idea for us to blunt immune responses in older adults in the setting of immune senescence. Bless their hearts is all I can say.
Okay, thank you. Dr. Kobayashi, is there anything else you want to comment on?
No, thank you for your comments. Definitely these will be brought back to the work group for discussion. Thank you.
Thank you. And then just thinking out loud, I'm still stuck on Dr. Lehr's comment, I have to say. I don't know if there is a reasonable time frame or a time frame of expectation sort of with the ACA coverage around for the ones that plans that it applies to around timing of availability. It is anchored to ACIP recommendations and people define that differently, but maybe clarifying or having clarity around that would be helpful so that there's consistency. And I also just wonder from a transparency purposes, if people can publish what their policies are as it relates to preventive healthcare and sort of the timing of availability of these things, because it seems like there's a ton of variability that we're asking, again, our frontline clinicians to manage. And some of these are small practices. Not everybody's part of a huge health system. So I just want to advocate for people who are just trying to deliver preventive care and are actually carrying the cost of this for people to make it a little bit easier. Dr. Lehr?
So my research into the legalities of this is that the ACA requires coverage. The clock starts either when it's published or when it's approved by the CDC director. 1 year later, the insurance company has to implement the recommendation with the following plan year. So if we recommended PCV 15 in September of 2022, this September, the 1 year mark passed. And so the next plan year, which might not be until January 2024, is when those insurance companies are required to cover it. So that's as long as they can drag their feet, is my understanding.
Yeah, I mean, it's an opportunity. Thank you. All right, we will move on to the next session.
Grace, 1 second. I just had a question. In terms of the publication of the children's PCV 20, there is a document already that has been, so that should be, you should provide it to the insurance companies because it is in print.
It's in print, but that starts the clock. So they have a year.
Yeah, certainly just from a preventive health services standpoint, to be nimble and respond to particularly like infectious disease waves, it does feel like there's a better opportunity to do this. Okay, we're going to move on to the influenza vaccines virus session. And I believe we are going to go straight to a presentation by Ms. Samantha Olson on the effectiveness of flu vaccine during pregnancy against flu-associated hospitalizations and ED visits in infants less than 6 months of age. And thank you again, everybody, for allowing us to move those presentations to today.
Thank you. And thank you for the opportunity to present this work to the committee. Next slide. Influenza virus infection during pregnancy is associated with severe disease and may be associated with some adverse birth outcomes. Next. Receipt of an activated influenza vaccine during pregnancy is safe and effective. Since 2012, WHO has recommended prioritizing vaccinating pregnant persons against influenza, and vaccination has also been recommended by the CDC. Since the COVID-19 pandemic, influenza vaccination uptake during pregnancy is about 5 to 15% lower than pre-pandemic seasons. These vaccination rates have decreased despite evidence that influenza vaccination during pregnancy can protect not only mom, but also infants less than 6 months of age who are not yet age eligible for vaccination and are at high risk of serious influenza-related complications. Next. The primary body of evidence for the protection of infants born to mothers receiving influenza vaccine during pregnancy are randomized control trials conducted outside of the US that showed a maternal vaccine efficacy against laboratory confirmed influenza in infants of 30 to 63%. However, there is a lack of real-world, multi-center, multi-season, and US data on maternal vaccine effectiveness against medically attended influenza in infants. In particularly, data post the 2009 H1N1 pandemic are limited, and data on maternal vaccine effectiveness by timing during pregnancy are limited. Next slide. I also wanted to comment quickly on the current ACIP recommendations for influenza vaccination in pregnant persons. As of the 2021-2022 influenza season, vaccination during July and August can be considered for pregnant persons who are in the 3rd trimester. For pregnant persons in the 1st or 2nd trimester during July and August, waiting to vaccinate until September or October is preferable, unless there is concern that later vaccination might not be possible. Next slide. So this brings us to our research question for this study. Does maternal influenza vaccination during pregnancy reduce influenza-associated hospitalizations and emergency department visits in infants less than 6 months of age? Next slide. For this analysis, we use data from the New Vaccine Surveillance Network, or NVSN. NVSN monitors pediatric inpatient and emergency department visits for acute respiratory illness at 7 pediatric medical institutions across the country. NVSN conducts respiratory surveillance year-round for infants and children through 17 years of age by collecting clinical testing results and conducting research testing at each of these sites. Next slide. So the methods for this study, we enrolled infants less than 6 months of age admitted to the hospital or emergency department during 4 influenza seasons, from the fall of 2016 through the spring of 2020, right before the COVID-19 pandemic, at 7 pediatric medical centers within the NVSN that was shown on the previous slide. Our cases were defined as infants that tested positive for influenza by RT-PCR with acute respiratory illness symptoms within 10 days of symptom onset. Our controls tested negative for influenza with those same ARI symptoms. The design of this study was a test negative design where the odds of maternal influenza vaccination greater than or equal to 14 days prior to delivery in our case infants with influenza were compared to control infants with non-influenza respiratory illness. We define vaccination as any influenza vaccine received during pregnancy, and we used a number of different sources. We looked at documented vaccination sources, such as state immunization information systems, and our sites also reached out to providers for documentation of vaccination during pregnancy. We also used self-reported vaccination if timing was provided, and that included either a date or if the trimester that the vaccine was received during pregnancy was self-reported. And data on maternal influenza infection during pregnancy was not collected and thus could not be assessed as a confounder in this analysis. For the statistical analysis, we used the equation vaccine effectiveness equals 1 minus the adjusted odds ratio times 100%, and we adjusted for infant age, NVSN site, and calendar time. We also looked at a few other potential confounders, such as influenza season, sex, race, ethnicity, prematurity, underlying conditions, and mother's education, but none of the other confounders were found to be significant. So we used the model that was specified on this slide. Next slide. And before going into the results, I'd just like to take a moment for us all to think through the complexity of maternal vaccination timing during pregnancy. To orient you all, this is a figure to think about the age of an infant during influenza season in the context of when maternal vaccination was received during pregnancy. Next slide. I'll start by walking through this orange group first. These show a few examples of pregnancies that have early opportunity to receive influenza vaccine. Their pregnancies start in September or October, the same time that flu vaccine is recommended to the general public. Next slide. Infants born to these mothers will also be older during the influenza season. They will be born in the summer months and will be about 4 to 6 months of age during flu season. In this group, we hypothesize to have lower vaccine effectiveness. Next slide. There's a second group shown in blue that represent pregnancies with opportunity for vaccination later in pregnancy. These are pregnancies that begin in the spring, such as March or April, and end in the middle of flu season around December to February. Vaccination would be received later in pregnancy. Next slide. And these infants would be about 0 to 3 months of age during flu season. And we hypothesize this group would have higher vaccine effectiveness. Next slide. So ultimately, considering timing to protect both mom and baby against influenza is complex, and strategies for maternal influenza vaccination will differ from vaccinations that protect against pathogens without a distinct seasonality, such as strategies for maternal vaccination that were used during the COVID-19 pandemic. Next slide. Now for our results. Next slide. We had 4,049 infants less than 6 months of age enrolled between the 2016-17 through the 2019-20 flu seasons within MVSN. Next slide. 285 were excluded. We had 92 infants that were born to mothers vaccinated less than 14 days prior to delivery, and 193 that had unknown vaccination timing. Next slide. 3,764 infants were ultimately included in this analysis, and 53% were born to vaccinated mothers. Next slide. We had 223 case infants testing positive. Next slide. And 3,541 control infants testing negative. And I circle this 54% because this is our vaccination coverage. We typically look at our controls to assess that. And this was really similar to what other surveillance systems showed for vaccination coverage for influenza among pregnant persons during these seasons. Next slide. So this is our table 1. And just to orient you, we have case status at the top, case infants that tested positive for influenza, and then by control infants that tested negative for influenza. And then we also show by maternal vaccination status. So those infants born to vaccinated mothers compared to those infants born to unvaccinated mothers. Next slide. So case infants and those born to unvaccinated mothers were older than our control infants and those born to vaccinated mothers. Next slide. Infant case status and maternal vaccination status differed by race and ethnic group. Next slide. More infants born to vaccinated mothers were breastfeeding on enrollment, and more infants born to unvaccinated mothers had underlying conditions. Next slide. And this is a continuation of that table 1. Next slide. More infants born to unvaccinated mothers were born preterm. Next slide. and vaccination status differed by NVSN site and flu season of enrollment. Next slide. So here are our main results: maternal vaccine effectiveness against influenza-associated hospitalizations and emergency department visits in infants less than 6 months. Next slide. Overall, maternal vaccine effectiveness against influenza hospitalizations and emergency department visits in infants less than 6 months of age was 34%. Next slide. Maternal vaccine effectiveness was higher among infants less than 3 months of age, among those born to mothers vaccinated during their 3rd trimester of pregnancy, and against hospital admission. And to quickly walk through those results, for those younger infants, we saw a VE of 53%. When we look by trimester, for infants born to mothers vaccinated during their 1st or 2nd trimester of pregnancy, we saw a VE of 17%. When we looked at those infants born to mothers vaccinated later in pregnancy during the 3rd trimester, we saw a higher VE at 52% with overlapping confidence intervals. And then when we look by severity of the infant's illness, our hospital admission vaccine effectiveness was 39%. And for ED visits, it was a little bit lower at 19%, again, with overlapping confidence intervals. Next slide. And maternal vaccine effectiveness was consistent with other VE estimates by influenza type and subtype for these same seasons. So if we look at adults or pediatric populations, we saw similar trends to what we see here. And to walk through that, that was a VE of 25% against influenza A. H1N1 was 39%. H3N2 was 16, so a little bit lower, again, similar to what we saw in those other populations. And then for influenza B, a little bit higher at 47%. Next slide. So in summary, influenza vaccine uptake during pregnancy is nationally consistent, but suboptimal. And again, I point to those recent estimates showing that vaccination coverage for pregnant women for flu has gone down since the COVID-19 pandemic. Maternal vaccination was associated with reduced odds of influenza hospitalizations and ED visits in infants less than 6 months of age. VE was greatest among infants less than 3 months of age, those born to mothers vaccinated during their 3rd trimester of pregnancy, and against influenza-associated hospitalizations. And lastly, there are no anticipated changes to vaccination timing recommendations during pregnancy. Next slide. And I would just like to thank the New Vaccine Surveillance Network and all the collaborators listed on this slide. I also would like to thank Texas Children's Hospital, who really co-led this project with us. And thank you so much for the time, and happy to answer any questions.
Thank you very much for the presentation. This presentation is now open for questions. Ms. Hayes.
Yes, I wanted to just thank you. This is just incredible data. It's so reassuring. I realize that the uptake is low, but the fact that we can prevent hospitalizations and infants is just a wonderful thing. Thank you for this research.
Thank you so much.
Ms. McNally.
Is there information regarding the reason for the decrease in uptake? And I'm wondering also what Tdap rates are showing during pregnancy. Thank you.
Thank you for that question. I don't have specific information on that, and that actually is more our ISD colleagues, who I don't know if anyone's in the room to provide some information around that. But happy to get back to you and chat with those other colleagues around that. And we didn't look at Tdap in this study.
Appreciate the question, Ms. McNally. The whole, again, I like platforms. So pregnancy platforms and just thinking about how to optimally protect our moms and babies is really thoughtful way to approach it. Are there any other questions? Okay, thank you so much, Ms. Olson. We are going to move on to the next presentation. Dr. Rebecca Condor will be speaking about an update on influenza B and Yamagata surveillance.
Well, thank you everybody for allowing me to give you an update during your informational meeting. I know it's at the end of a long couple of days. So next slide, please. I wanted to give an overview of the global surveillance for influenza. This has been conducted for over 75 years through the Global Influenza Surveillance and Response System, coordinated at WHO. It's a growing system of national influenza laboratories, regional laboratories, and WHO collaborating centers, as well as essential regulatory laboratories. This includes a mission to protect people from the threat of influenza by continuously functioning as a global mechanism of surveillance, preparedness, and response for both seasonal, pandemic, and zoonotic influenza. It's a global platform for monitoring for influenza epidemiology and disease, and it's a novel alert system for influenza viruses with pandemic potential. And as we've known previously, it's been used now for other respiratory pathogens. Next slide, please. So this map shows the location in the very small blue triangles of the national influenza centers. There's over 150 found worldwide. And the job of the national influenza centers are to collect respiratory specimens through an established network of physicians, healthcare centers, or other sentinel sites, or collect in influenza-positive specimens. They're then responsible for performing influenza typing and subtyping through assays developed at CDC and available through the IRR. The other important part of the National Influenza Centers are sending in representative specimens into the WHO collaborating centers for additional phenotypic, both antigenic and genetic characterization, and create the basis of new candidate vaccine viruses used globally. The reporting mechanisms through WHO is through RespiMart, and there are two sections, an epidemiological information through FluID, and a laboratory results through FluNet. Next slide, please. And just to mention that the influenza division at NCRD CDC serves as a WHO collaborating center for surveillance, epidemiology, and control of influenza, looking at both the epidemic human influenza as well as the zoonotic influenza globally. So when we look at our surveillance data available in FluNet, we can delineate by the type of surveillance site that the country has available. This includes sentinel surveillance. So rich, high-quality data that's produced in a timely manner, systematically and routinely sampled from sentinel surveillance sites, which represent populations with case definitions, such as influenza-like illness, severe acute respiratory illness, or acute respiratory illness. Depending on the country, you'll have a different level and type of surveillance being done and different age groups. Another characterization of surveillance is non-sentinel, and this is a data reporting category that can include outbreak investigations, universal testing strategies, or testing at point of care, or other systems that are apart from their sentinel surveillance. And then lastly, type not defined, which could include both sentinel and non-sentinel. And each country has a mixture of different types of surveillance that they perform. But the level of information that's available per country and per surveillance network really kind of depends on the source of the influenza testing. When there's rapid tests being done at primary care or other clinic levels, in this case, you'll only get typing results of influenza A or B. In large clinical and hospital settings, you're often using large panel respiratory panels that may only type, so influenza A or B, or in some cases provide the influenza A subtype as well, but do not provide the influenza B lineage type. And what you'll see, and I'll show in a couple of slides, is that the sentinel surveillance performed by these national influenza centers through their networks, the laboratories and the NICs are the ones that do the full subtyping for influenza A and the full B genotyping. So you'll see a higher proportion of influenza B genotype information from those sources. Next slide, please. So the types of assays that are available for influenza B genotyping are really based on whether there's serology. Through serology, we make available and create a WHO kit. This is using goat antiserum raised against B Victoria and B Yamagata viruses, which will be specific to that genotype. And that's available through IRR. And a good number of countries, over 52, have ordered this kit to use serology as their basis for B genotyping. We also can make available, upon request, ferret antisera, again raised to specific B Yamagata or B Victoria viruses, where they can use the HI assay to determine B lineage. Molecular-based assays are becoming more common, and CDC has created an RT-PCR B lineage assay for research use only, and this is available to the WHO National Influenza Centers via CDC's IRR. And over 100 countries are supported with kits to perform the B lineage assay. And then individual countries may have their own RT-PCR-based assays, or may use sequencing, either Sanger or next-generation sequencing, to determine the B lineage. What's reported to FluNet is from the country level. But as I mentioned, the GISRIS system involves the network of national influenza centers sending in representative specimens from epidemics in their countries into WHO collaborating centers for additional characterization. So all influenza B viruses received by WHO collaborating centers also have their B lineage determined, again using the similar methods. And as has been mentioned before, since March 2020, there have been 0 circulating B Yamagata lineage viruses confirmed through the WHO Collaborating Center and GISRIS network. And we'll go into some of the reports of B Yamagata, but mainly these have been due to incorrect lineage, either upon retesting being negative, or identifying an individual that has been vaccinated with an LEIV and sampled post-vaccination. And then in non-sentinel surveillance, there could be a different set of assays. I just don't have an exhaustive list. Next slide, please. So I wanted to give a reminder of where we were before the COVID-19 pandemic for the co-circulation of the 4 influenza viruses that we have in our influenza vaccine to protect against. These graphs split up the results to FluNet into the Northern Hemisphere and Southern Hemisphere seasons, with percent positivity in red and different colors for the influenza A and influenza B subtypes and lineages. The different aqua colors are the influenza A subtypes, and then the orange and the light orange are those for influenza B. The darkest orange represents the influenza B viruses where lineage was not performed. The middle orange is for B Victoria, and the light orange or slightly yellow is B Yamagata, to orientate everyone. If we look at the seasonal epidemics in the Northern Hemisphere and the Southern Hemisphere, we can see that B Yamagata was the predominant B lineage in circulation during the 2017 to 18 Northern Hemisphere and 2018 Southern Hemisphere seasons. So this was a pretty big B Yamagata epidemic for both hemispheres. When we moved into 2018-19, we saw very little B Yamagata and B overall, but the majority of that was B Victoria. And during the Southern Hemisphere of 2019, we saw regional differences, where B Yamagata was responsible for circulation in epidemics in South America, but not seen in other parts of the Southern Hemisphere. The 2019-20 Northern Hemisphere season was a little bit unusual in the timing of the B influenza activity. It was quite early in the season, and it was predominantly a new group of B Victoria viruses. We're calling that the triple deletions. This was quite large and quite early in the United States, and it was followed by an H1N1 peak as well. But as has been said before, the COVID-19 pandemic and its mitigation strategies saw a dramatic drop in the detection of influenza viruses and circulation in 2020. Next slide, please. As we look at post-2020 data, we had the continual surveillance occurring at national influenza centers. They continued to look for flu, but they did not find it, or they did at very low levels. So there were not significant epidemics during this time. We started to see an increase in epidemics at the end of 2021, and at that time, all B influenza activity was again just Victoria. If we go into the more recent seasons, the previous 2022-23 Northern Hemisphere season actually saw a second peak of activity in some parts of the Northern Hemisphere due to co-circulation of both B and H1N1. And during the Southern Hemisphere 2023 season, again, B Victoria and H1N1 predominated. And it was of note that over a third of the viruses detected during the February to August timeframe were of the B lineage. Next slide, please. So this map shows for the same reporting period, February 1st to August 31st, looking at all types of surveillance, which laboratories were reporting influenza B and the B lineage results. We can see that several countries globally detected influenza B viruses. And so we have a very strong, very diverse, geographically diverse network reporting data. The proportion that are reporting B lineage depends on the region, and again, as I mentioned, the different surveillance networks and types of testing present that are reported by that country to FluNet. But quite a few in several different regions of National Influenza Centers report B Victoria and B Yamagata lineage results to FluNet. Next slide. If we look at this graph over time, what I can tell you is during this time frame, there was one single B Yamagata that was reported to FluNet from a non-sentinel source. So no other surveillance during this time period detected B Yamagata. And you can see the proportion that had B lineage results was low, but as I mentioned, that can be due to the types of surveillance networks in the countries. If we go to the next slide, when we look at sentinel surveillance, we can see a much higher proportion of B lineage information being reported immediately to FluNet. And next slide, please. So if we look cumulatively at the data presented from our national influenza centers from February to August, almost 100,000 influenza B viruses were detected in over 139 countries. Of the reports for the B lineage results, almost 16,000 had results reported. And we looked at those results. We had 15 initial reports of B Yamagata. However, we followed these up through the WHO collaborating centers and the Global Influenza Program staff. When we looked at these 15 reports, 13 were able to be confirmed as B Victoria and transcription errors, or turned out to be negative for influenza, and so their records in FluNet were updated. We do have two that have specimens that were not available for confirmation, so we were unable to verify the report of B Yamagata. However, for these particular specimens, we also, the lab that was able to detect it was not able to get a virus isolate or have virus sequence data to confirm their results. When we look at what was sent in representatively from our national influenza centers to WHO CCs, all were B Victoria. And if we look at our genomic surveillance data, looking not only in the 8 different gene segments, we can detect and not detect any B Yamagata genetic information. It's all the circulating B Victoria lineage data. So during this surveillance time period, this data continues to support that B Yamagata viruses are extremely rare and not responsible for recent epidemics, and that the majority of Yamagata reports are due to an incorrect lineage determination. Next slide. So I wanted to talk about how the Vaccine Recommendation Committee came to the recommended viruses for the trivalent and quadrivalent vaccines. This map, or this shows the virus lineages that were recommended. And you can see that the B Victoria maintains its lineage in the trivalent composition. For quadrivalent, the B Phuket, which is a B Phuket 3073 2013 antigen, has remained the recommended virus to be included in the quadrivalent vaccine. And there has been no data available to make a change in that recommendation. And the WHO recommendation and technical reports are available on the WHO website. And the WHO recommendation committee will continue to recommend viruses for licensed vaccines. And since the currently licensed quadrivalent vaccines are for 1H1, 1H3, 1B Vic, and 1B Yam, they will continue to recommend a vaccine virus for the B Yamagata component. Next slide, please. So due to the absence of B Yamagata surveillance since 2020, the committee found that there's a very low risk of infection for B Yamagata viruses and felt it was important that their opinions on how this information is forming their recommendations be stated. And so they wanted to include in the recommendations understanding what were the risks of, where are the risks for B Yamagata highest? And that includes during the manufacturing process of the vaccines, as well as continuing to have quadrivalent vaccines, LEIV, that contain a B Yamagata component. Because there could be a theoretical risk of reintroducing B Yamagata back into circulation with these processes. So it's the opinion of the committee that the inclusion of the B Yamagata antigen as a component of influenza vaccines is no longer warranted. And in order to mitigate the above risks, the committee recommends that the B Yamagata lineage virus be removed from the vaccines as soon as practically possible. And the committee wanted to recognize that they'll continue to recommend what viruses should be available for each vaccines. But it's then at the national or regional authorities' responsibility for the approval for the composition and formulation of vaccines licensed and used in each country. And requests in light of the B Yamagata information that committees then consider the use and relative benefits of currently licensed trivalent and quadrivalent vaccines. So mitigating the risk of Yamagata could be done through trivalent vaccine instead of quadrivalent vaccines. The FDA convened a VRBPAC committee meeting in early October to discuss the Southern Hemisphere manufacturing recommendations for vaccines and agreed that the B Yamagata lineage antigen should be excluded as a component of the vaccines as soon as possible. So now there are ongoing efforts by vaccine manufacturers who have inactivated trivalent licenses, so licenses that are no longer, that are in an inactive status, to reactivate these licenses. And they're working closely with our FDA CBER colleagues on this issue. Next slide, please. So what can you expect in terms of surveillance going forward? CDC is going to continue to support international laboratory capacity for influenza detection and influenza A subtyping and B lineage determination through our reagent availability in IRR. Our GISRIS National Influenza Laboratories are committed to continuing to perform the B lineage assay and report the results in a timely manner to FluNet. Any reports of B Yamagata will be promptly followed up by WHO and the WHO collaborating centers. In addition, in the United States, our U.S. public health laboratories will also continue to perform influenza B lineage testing. And as an added precaution, we've requested that any detections of B Yamagata be sent into CDC for confirmation. Additionally, we're asking for the detection of any co-infections of either 2 influenza A's or 2 influenza B's also be sent into CDC for confirmation. Since we've previously seen these types of mixtures during the vaccine campaign part of the season and want to understand whether these individuals are had recently received LAIV in the weeks prior to sampling. Thank you very much for your time, and I'm happy to take any questions.
Thank you. This presentation is now open for questions. Dr. Paling.
I want to just say thank you for this incredible surveillance. This is really important. And it is also important that as virus circulation changes are what's included in vaccines does. And I think that enhances confidence in all the work that's being done. So it's just a thank you.
Thank you, Dr. Paling, and thank you, Dr. Condor, for your presentation. It's a really excellent update. We will move on to the last presentation of the day. Dr. Greg Sylvester from Seqirus will be providing updates on pregnancy outcomes with CCIV4, results of a post-marketing study.
Thank you very much, and good afternoon. As you've heard, my name is Greg Sylvester, and I am the Chief Health Officer at CSL Seqirus, a vaccine manufacturer. I will be presenting the results of our prospective observational cohort study evaluating the safety of CCIV4 among people immunized as part of their routine obstetrical care. Please note, I will be using the brand name Flucelvax instead of CCIV4 for the remainder of my presentation. Next slide, please. Flucelvax is not produced in fertilized eggs. The influenza viruses are propagated in mammalian cell cultures that are an exact antigenic match to the original viruses recommended. The data that I will present was added to our US package insert in February. This flu season is the first time these data appear in the Flucelvax label. You can see on the slide, the purpose of the study was to fulfill a post-marketing commitment with the FDA as part of the licensure process. The main objective was to study the safety of Flucelvax with regards to specific pregnancy and infant outcomes, and I'll discuss those in more detail in the next slide. But the study was designed as a pregnancy exposure registry in line with the FDA guidance. Oh, one more, let's go back. Sorry, yeah. The expert, an expert panel was assembled to review the findings. And when it came to congenital malformations, a teratologist reviewed each defect. He was blinded to the time of exposure of the vaccine. He reviewed and classified the reported malformations using the Metropolitan Atlanta Congenital Defects Program classifications. The MACDP is a birth defect surveillance system established by the CDC in 1967 and is considered as a gold standard in birth defect surveillance systems. An expert panel of independent medical professionals was assembled to oversee this study. The committee was comprised of experts in the fields of obstetrics, maternal fetal medicine, pediatrics, clinical research, infectious disease, epidemiology, and as I've mentioned before, genetics and teratology. Next slide. Here are the pre-negotiated outcomes of interest with the FDA. You can see live birth and stillbirth. For spontaneous abortions, they were reported as a fetal death that occurred less than 20 weeks in gestation, and you can see the definition for elective termination. On the right side are events of interest: preterm birth, low birth weight, and major congenital malformations. We use standard medical definitions for these outcomes. And as for the malformations, we included any major or chromosomal defect or a combination of 3 or more conditional defects in live, stillborn, or fetal losses at any gestational age. Next slide, please. Here are the criteria to include or exclude participation in the study. Participants were enrolled prospectively by obstetric healthcare professionals who had committed to enrolling all eligible persons in their clinic who consented to the study. Participants from whom sufficient data was available to confirm the data receipt of the vaccine, determine pregnancy outcomes, and to evaluate whether an event of interest had occurred in the fetus or infant at the time of the pregnancy outcome were enrolled in this study. We used a passive and an active system, and I'll show you that in the next slide, but retrospective cases were ineligible for enrollment, as were persons who had prior knowledge of an adverse pregnancy outcome, such as a major malformation suggested by prenatal testing. These cases would be reported to our pharmacovigilance system within our company. Next slide. This study was conducted over 3 flu seasons. The flu season, we used passive enrollment process. In other words, we solicited enrollment via the internet. We posted eligibility requirements on clinicaltrials.gov, our Securus website, and on the Society of Maternal Fetal Medicine website also. As you can see, we were not successful, and then we changed our enrollment to active participation for the remainder of the study. There were 5 study sites in 4 states, in Georgia, North Carolina, New York, and Idaho. As you can see in the middle of the slide, our total enrollment was 693 pregnancies. We lost 27 participants to follow up, and 1 individual was deemed ineligible because they enrolled retrospectively. Therefore, the last number, the primary analysis population, is 665. Just to note, the demographic characteristics of those lost to follow-up were similar to those that completed the study. A sample size of at least 600 would provide adequate power to detect a 2-fold increase in major congenital malformations, which was the lowest rate of detection amongst our outcomes. Next slide, please. Here are the demographics of the participants in the study. I think they're fairly typical. Please note that under the 3rd heading that's bolded, there's nearly 28% missing data as it pertains to ethnicity. It turns out that 1 of the 5 enrollment sites did not report ethnicity in their medical records. If you look at the last category of race, we enrolled 60% white, 29% African American, and 4.4% Asian. Next slide, please. Here are the baseline characteristics. The mean and median of the pre-pregnancy BMI were both in the high 20s with a wide min-max range. The number of previous pregnancies were fairly equally distributed. The history of a congenital malformation was reported as a small percentage amongst offspring, but larger percentages amongst maternal, paternal, and any family history. As you can see, there was a high percentage of concomitant medication use, which included prenatal vitamins and Tdap vaccination. Next slide, please. Here is a graph of the gestational age when Flucelvax was administered as part of their routine obstetrical care. The x-axis is the gestational age of exposure measured in weeks, and the y-axis is the number of exposures. In red, 28% of vaccinations occurred in the first trimester. In blue, 41% of the vaccinations occurred in the second trimester. And in green, 30% vaccinations occurred in the third trimester. We enrolled approximately 1/3 of patients before 20 weeks of gestation. Next slide, please. Here are the results. If you look at the last column in the top right-hand corner, you'll see 99.1% of births were live. There were no stillbirths, and just for the record, no maternal deaths reported in the study. As mentioned earlier, we analyzed spontaneous abortion, and since only 1 elective abortion occurred, and it occurred before 20 weeks, we looked at that also, showing 2.7% and 0.1%, which comprised of 4 spontaneous abortions and 1 elective termination. Not reported in the slide is one ectopic pregnancy, which was not part of our pre-specified outcomes. Next slide, please. Here are the events of interest in the fetus or infant. Please note that the gray bars are US background rates determined by the National Center for Health Statistics for premature birth. They reported 10.2% of live births are premature. For low birth weight, we use the prevalence rate from the National Vital Statistics System. They report 8.3% of live births are low birth weight. And finally, we use the Metropolitan Atlanta Congenital Defects Program major congenital malformation rate of 2.8% of live births, or stillbirths or any fetal loss in any gestational age. The bars in red are our study results. Please note that the point estimates above the red bars are below the US background point estimates. We did perform a one-sided 95% confidence interval seen by the thin black line above the red bars. We attempted to look at the US prevalence rates for preterm and low birth weight confidence limits, but did not come across them in our research. Next slide, please. Taking a closer look at the major congenital malformations, we see a diverse set of malformations were identified and classified. We did not see any clustering of any single type of birth defect, nor did we see a clustering of groups of defects, such as midline defects. The expert committee reviewed individual reports as well as aggregated data and found no pattern amongst the reported events. On the right-hand side of the slide, just below the words preferred MACDP term is the key. The birth defects in blue denote those that have a known cause. The birth defects in green denote that there is no temporal association. And the birth defects in orange denote that the teratologist as well as the scientific oversight committee were unable to assess temporality. Next slide, please. Every study has certain strengths and limitations. We enrolled more than 660 subjects across 3 influenza seasons. We enrolled a diverse population, which included racial and ethnic groups, as well as broad range of maternal ages. And we used 5 study sites in 4 states. However, there are limitations. The effect of a potential confounders cannot be ruled out. The potential for missing data not found within the medical records. And the Metropolitan Atlanta Congenital Defects Program counts major congenital malformations detected up to the age of 6. We could potentially have missed additional cases. And finally, the conclusion, next slide. These findings are consistent with published data from various databases and surveillance systems that monitor the safety of influenza vaccines during pregnancy. The committee of independent experts concluded that there was no evidence of a safety concern from the data in this study. And this data supports the use of Flucelvax during pregnancy. Thank you very much for your time.
Thank you very much for your presentation. It's now open for questions. And I just, wanted to add my thanks for doing this study and focusing on the pregnant population. It's incredibly helpful.
Thank you.
Does anyone have any questions? ACIP members, liaisons? Dr. Sylvester, you may have left everyone speechless.
Well, that or the time of day after a day and a half, a very long meeting. So thank you very much for giving us the opportunity to present this to you all.
Thank you so much. We really appreciate it. Okay, I think that is our last presentation for today. Dr. Wharton, do we have any additional business?
Dr. Lee, I do not.
Okay, good to know. Well, let's just take a moment to thank all of our speakers, our ACIP members, ex officio members, liaison members, and the incredible CDC staff for all your work that contributed to the really thorough and thoughtful presentations over the last 2 days. We are very appreciative and again, want to express our appreciation that the CDC has this federal advisory committee to ensure that there is a public process for reviewing these data. Since there are no other items for us to discuss, are there any objections to adjourning today's meeting?
Dr. Lee, before you adjourn, I do just want to express our appreciation for our members whose terms ended in June, who have continued to serve as we have asked until our new members are named. So thank you to all of our ACIP members, but especially those who are continuing to serve.
Let me add my thanks to that cohort. And so we're announcing today's truly our last meeting. And hearing no objections or seeing no objections online to adjourning, I will declare today's ACIP meeting now adjourned. Thank you, everybody.